The broadcast is now starting. All attendees are in listen-only mode.
Name first because she is by far and away the more important of the two speakers this morning. We do have a couple disclosures. Both Dr. Zuckerman as well as myself received grant and research funding from Gilead Sciences, which is one of the multiple pharmaceutical companies that do produce hepatitis C medications. Our objectives today is first to describe the financial impact of hepatitis C virus on U.S. healthcare, to identify common restrictions of hepatitis C virus treatment among payers, and then finally to illustrate successful acquisition of direct-acting antiviral therapy. The focus of our presentation really is going to be on that third bullet point, because I think this is a significant issue and challenge for all groups of providers, whether they're highly experienced with hepatitis C evaluation and care, or if they are just starting clinical programs to impact their clients and patients. For a brief outline, this is where we're going to go over the course of this webinar. I will give a brief hepatitis C virus review, as I recognize there's likely a wide variety of folks in their clinical experience with hepatitis C. I want to make sure we at least start on the same page as it pertains to hepatitis C and as it pertains to hepatitis C treatment. Next, I'm going to talk about hepatitis C virus and healthcare finances, and to give a little bit of an idea of why we run into issues so often with accessing therapy. I will then turn it over to Dr. Zuckerman, and she's going to go through fairly significant detail about how to navigate the healthcare system for both patients with prescription insurance and those who have no prescription support. She also has a large assortment of tools that can be used for manufacturer patient support as well as treatment access resources, as this may make a major impact for obtaining therapy in different patient populations. And then finally, she'll comment on how she anticipates access to change over the coming months and coming years. So at a very basic level, we often brush over the fact that hepatitis C virus is an infection. It is one that's caused by an RNA virus that's commonly spread through blood and body fluids, and predominantly infects and makes additional copies of itself within liver cells. An important highlight from the biology standpoint is that hepatitis C virus does not have a hiding spot. It does not have a reservoir within the body. Thus, if we can eradicate hepatitis C at any one instant in time from the human body, we feel that this is a virus that can truly be cured long term, as compared to other viruses such as HIV, where we can suppress a viral infection, but we have not found a way to eradicate it thus far. Hepatitis C in the United States has been an increasingly important issue, and you can see why that is the case as you look at these two graphs. These are actually relatively old figures from 2010, but what they illustrate is that from the 1950s, 60s, and all the way up to the year 2000, there was a significant increase in the rates of those who were ever infected with hepatitis C, those who developed chronic infection, and then a somewhat delayed impact on those who developed cirrhosis. The right graph shows that the rates of hepatocellular cancer in liver failure or decompensated cirrhosis is actually peaking over this time period in the late 20-teens and into the early 2020s. Below, you notice that we have a very wide range of estimates for hepatitis C in the United States. Some papers will quote as low as 2.7 million patients with chronic hepatitis C. Others will estimate as high as 5.2 million, and that's based on using small population statistics to infer what's happening across the U.S. population. The lower statistics are in generally more insured and relatively healthier cohorts, whereas the higher estimates include folks who are in more difficult social circumstances, those who are in mental health institutions, currently hospitalized, those who are homeless, those who are in prisons, and other harder to track groups. Ultimately, what is not debated is that there's a significant portion of the U.S. population who are infected with hepatitis C. HepView.org is a project supported by the Emory University Rollins School of Public Health, and it actually gives fairly regularly updated statistics as well as a variety of different tools to help us visualize hepatitis C prevalence in the United States. I don't know where everybody is signed on from throughout the United States, but you likely can see where your region is reflected in this particular state map, focusing on prevalence of hepatitis C per 100,000. I think it's important to highlight that this graph and map is based on the NHANES survey, which is one of the lower estimates for chronic hepatitis C infection, based on 2.7 million people infected with hepatitis C. Again, one of the things that's not debated, that while we recognize that hepatitis C has a wide range of prevalence states, we recognize that hepatitis C absolutely is contributing to significant mortality in the United States. In fact, hepatitis C overtook all other nationally notifiable infectious conditions as of 2012 as a cause of death in the United States. All of these other nationally notifiable infectious conditions includes any infectious condition that the CDC tracks, including HIV, hepatitis B, tuberculosis, and a variety of other infections. Yet hepatitis C is overtaking all others as a direct infectious disease cause of death. One of the things that's important to highlight, especially anytime I give a webinar or anytime I speak with a large group, is discuss who's at risk for hepatitis C. And many people are aware of some of the bigger push to screen those born between 1945 and 1965, the so-called baby boomer cohort. But in addition to that, it's important to highlight that those who have additional exposures or have additional risks or who have particular behaviors that put them at risk should be screened. Some of those are listed along the left. But you can really summarize the hepatitis C screening indications based on this slide that has been prepared by Dr. Zuckerman. And this is based on the AASLD and IDSA hepatitis C treatment guidance recommendations as of this year. One-time hepatitis C screening is recommended for all persons born between 1945 and 1965. In addition, those who have risk behaviors, including injection drug use or intranasal illicit drug use, those who have risk exposures, including dialysis, getting a tattoo in unregulated settings, those who are healthcare workers with potential exposures, children born to hepatitis C infected women, those who have had prior transfusions or organ transplants prior to 1992, or those who have ever incarcerated should be screened. In addition, those who are HIV infected, those who are going to start HIV pre-exposure prophylaxis based on sexual activity, those with unexplained chronic liver disease, as well as solid organ donors are all groups that should be considered for hepatitis C screening. Indeed, just within the past few weeks and months, all pregnant women are now recommended to be screened for hepatitis C based on the WSC IDSA treatment recommendation and guidance. Why this is so important is that a significant proportion of the U.S. population who are infected with hepatitis C are unaware of their diagnosis, approximately 50% based on prior estimates. What we're going to focus on today, however, is once someone is diagnosed and they have access to outpatient care, how they can successfully navigate the rest of the cascade of care, and perhaps the most important piece of that is accessing hepatitis C therapy, which is one of the most challenging parts from a logistical standpoint. When we approach treatment for hepatitis C, there's a wide variety of things that need to be assessed, from hepatitis C genotypes to how much scar tissue is within their liver, assessing liver function, assessing what type of treatment they may or may not have had in the past, assessing other things that could affect their health, as well as choosing a hepatitis C treatment regimen and determining a duration. This could be the component of many webinars and indeed full-day programs. And so there are multiple different options for resources that can better educate the audience if additional insight is requested in this regard. What our focus is going to be is not on prescribing therapy, although it is important to know that we have multiple different classes of therapy, some of which have come to the market and have now gone, such as telaprevir or boceprevir, and also to recognize that these medicines may be combined in a variety of ways and may be available as single agents or only available in combination agents from different manufacturers. Again, the focus of this webinar is not to know all the different names, to know all the medications, or to recognize which should be chosen and which should be prescribed in different settings. Our focus is actually pivoting to the next role, is hepatitis C and healthcare finances and how to navigate the system. People are, I think, relatively aware that hepatitis C medicines are quite costly, but I think a lot of folks are not aware that there's a significant cost to people having hepatitis C and the healthcare delivered to that, especially in the absence of treatment. Liver disease itself can have a significant cost per patient per year. Those who have cirrhosis have more. Those who have end-stage liver disease and liver cancer, even more. And those who require liver transplant for further care, even further. We recognize that the cost of hepatitis C treatment has been very high at different points, peaking with combination of sofosbuvir and cimeprevir based on average wholesale prices of therapy. However, as you can see that over time with the introduction of multiple different combination therapies, the cost of prescription medicines based on average wholesale price has changed over time. And I think that's an important thing to highlight, that although the cost of hepatitis C as a disease remains, the cost of hepatitis C treatment has continually been in flux. That has led to a variety of different cost reimbursement and cost effectiveness analyses. Unfortunately, these analyses are significantly limited because the actual cost of direct-acting antivirals, active competition, and negotiated pricing makes it very difficult for us to have transparency into this process. Even within the guidelines, the authors state, quote, "To be clear, this section is informational. As explained below, actual costs are rarely known. Accordingly, the HCV guidance does not utilize cost-effectiveness analysis to guide recommendations at this time," basically stating that this is an area of open research, but to get appropriate cost-effectiveness data, we really need to have accurate knowledge regarding the inputs. Nobody argues that the medicines are expensive, and thus there have been a variety of different access restrictions been put in play by both public and private payers. Common restrictions include fibrosis stage, prescriber type, and substance use. Some payers also make additional restrictions based on HIV status, a once-per-lifetime protocol to limit reinfection retreatment, genotype restrictions, previous adherence requirements, especially pharmacy restrictions, as well as exclusivity agreements regarding the therapies that are chosen. We could talk about a lot of different aspects about access, but access is a major focus, and often Medicaid is one of the groups that gets the focus. The Center of Health Law and Policy Innovation at Harvard Law School has a project in partnership with the National Viral Hepatitis Roundtable, and they've graded access for Medicaid services across different states. And again, you know where you are, and you can see how your access fares as far as Medicaid program. However, this is not just a process that's a problem that's isolated to Medicaid. A recent publication within the past week in Open Forum and Infectious Diseases highlighted that across 16 months for over 9,000 patients, there was a 50% denial rate among private payers with normal insurance. There was a 34% absolute denial rate in Medicaid, and there was a 15% denial among Medicare. So this is an evolving and escalating issue in all states across all payers. And thus, our next focus is going to be how we navigate the system on behalf of patients. So I'm going to turn it over to Dr. Zuckerman at this point.
Hi and good afternoon. Thank you for joining us again. And as Dr. Chastain said, I will be presenting the rest of the webinar today, and we're really going to talk mainly about how to navigate the system after a prescription has been generated, after you've done all the evaluation to see what medication is appropriate for the patient and prescribed. So some of you may be the actual prescribers, some of you may be the clinic staff that helps with this process, and some of you might be very familiar with this process. But what we're going to talk about are two different patient groups, patients with prescription insurance and those without prescription insurance. And I have a couple case studies for the patients with insurance that we'll walk through to kind of help guide the conversation. So the first case is Gabriel. He's a baby boomer male with genotype 1A hepatitis C. No fibrosis was seen on ultrasound to F0. He's naive to treatment. He does have HIV co-infection, and he has private insurance through Express Scripts. Patient case 2, Lucas, is also a baby boomer male with genotype 1A infection who is treatment naive, but he has F4 fibrosis per FibroSure, which we would classify as cirrhosis, and he's a binge drinker with multiple rehab visits. His household income is $21,000 for a family of 3, and he has Medicaid insurance. So we're going to use these two cases to walk through the process of getting treatment. And this process is very similar across a lot of medications, especially within specialty pharmacy. And so I'll kind of show you this graphic of how the process after you prescribe a medication, the patient actually is able to access treatment. So it starts on the left-hand side in the blue where it says decision to treat. With many of our medications that are generic or not specialty, oftentimes no PA is required, and you're able to go ahead and send that prescription to a pharmacy with no problem. With the growing number of specialty medications, however, many times the pharmacy benefits manager or insurance company will require prior authorization, which is noted here as a PA. So if a PA is required, that's completed. If it's approved, great, then you can send the prescription to the pharmacy. If it's denied, then oftentimes you go to a first level appeal. If that's also denied, you can go to a second level appeal, and then sometimes an external review is required. If the patient goes through prior authorization, first, second level appeal, and an external review, sometimes the drug manufacturers will provide medication through the patient assistance program. So we're going to walk through this process with our case examples. So first is completing the prior authorization, and this can be done in a number of different mediums. So the first is paper or fax, and it may sound kind of antiquated, but it's actually really helpful for hepatitis C treatment because a lot of these insurance companies require a number of documentations that must be sent, clinical information and labs that must be sent as well. So in our practice, the majority of the time, we are actually obtaining a PA application online, printing that off, including all of our documentation, which I'll talk about on the next slide, and then faxing that back to the insurance company or PBM. The other option, which is growing, is an electronic form of prior authorizations, and this is one organization that we use is called covermymeds.com. All paperwork can be completed within CoverMyMeds, and then you can also upload that supporting materials that we've talked about and send it that way. So that's also a very viable option. Finally, the last option is to complete a prior authorization through the phone. This is common for many medications, but for these medications, it often leads to denial because, like I said, clinical information is typically required for prior authorization to be approved. So I would really encourage you not to use phone PAs for these particular medications. However, if a patient has already been approved and we need to extend the PA dates or extend treatment, that is an opportunity to call and do the prior authorization by phone. So what do you need to include in a prior authorization? First, every insurance company or PBM will have an application that needs to be completed. So obviously you want to complete that very thoroughly. If you miss anything on the application or don't complete it correctly, many times they will deny you outright. So it saves a lot of time to go ahead and be sure that you're completing that prior authorization thoroughly the first time. Second, we always include the genotype, if available, and the hepatitis C viral load from baseline. Any type of staging you have, so there's a number of staging mechanisms, which again is another conversation, but some listed here are ultrasound, CT, any FIB4 scores or Abbvie scores, anything that the provider has done to stage the patient to see how much fibrosis is on the liver should be included. We also include clinical notes. Oftentimes Dr. Chastain or our other providers will write why the patient needs the treatment, their background, their history, and so sometimes we will include those notes as well. There are other items that are sometimes requested by certain pharmacy benefits managers. So if you're prescribing Zepatier in a patient with genotype 1A, they will require resistance testing for that agent, as they should. Some PBMs will also require urine drug screenings and rehab documentation. So it's really important, again, to read through that application, make sure you're completing it appropriately and including everything it's asking for, as well as these clinical endpoints. Our typical practice is to follow up after we have faxed or sent in the PA if we have not received a response within 5 days. So we'll go through Gabriel's case. So he was the one with Express Scripts, and this is a sample prior authorization request for Harboni filled out for this patient. And you can see at the top it's asking what type of hepatitis C the patient has, Is it going to be used in combination with other therapies? Is it for retreatment? And then question number 5, does the patient have chronic hep C? Yes. And in this box, and there's a lot of these kind of branching logic questions on prior authorization forms. If yes, go to this question. If no, go to this question. And I would just encourage you again to be thorough in reading these. If you miss questions, they will deny you even if the patient meets criteria. So it's very important to look at that. So in this instance, if no, go to question 11. Question 11, does the patient have recurrent hep C after transplant? The answer is no. And so then we're going to proceed to question 17. Does the patient have hep C? Yes. This particular PBM actually requires the medication to be prescribed by or in consultation with a specialist. So I do work in an infectious diseases clinic, so we were able to answer that. I will say for primary care physicians, this requirement is decreasing. We're having less people less PBMs require a specialist to prescribe. But there are a number of different ways that you can consult with a specialist, including the South Carolina AETC telehealth program. So that is an option. Moving on, does the patient have advanced fibrosis? No, this patient did not have any fibrosis. Are they treatment naive? Do they have cirrhosis? What is their baseline viral load? And have they been previously treated? And so at the end, I typically write just a synopsis, a summary of this patient and why this patient needs treatment. So he has genotype 1A hepatitis C complicated by HIV co-infection, placing him at high risk for fibrosis progression, and Harvoni is compatible with his current HIV ART. Moving on to patient case 2, Lucas. Lucas had our Medicaid, which is TennCare, and this is what one of their forms for Mavorette looks like. So you can see at the top it's mainly patient information. At the bottom they require baseline HCV RNA. And then the questions are pretty concise, what genotype the patient has, if they have compensated or decompensated cirrhosis. And you'll note here that they kind of require certain documentation for staging. So I list each of these staging mechanisms that we have, and then I'll also include all of the information from those different staging mechanisms when I fax this form back in. Again, our Medicaid requires some sort of specialist to prescribe the treatment at this time. And then number 7, this is huge for a lot of state Medicaid agencies. TennCare requires, if the patient has a history of illicit substance or alcohol abuse, that some sort of recovery program or counseling services must be included. So I have here that the patient has been to rehab, and I will include that information when I fax it back in. Our state also requires 6 months of sobriety from substances as well as alcohol, and this patient did not meet that requirement, so we had to put no on the alcohol abuse within the last 6 months. And then the other questions are more clinical in nature, asking about end-stage liver disease. And then question 14, we had to know the preferred agent for TennCare was Vicura at that time. So if we did not want the patient to receive that, why? And you can see that that's no longer recommended in genotype 1A with cirrhosis. And then again at the bottom, we put the summary. So the patient has genotype 1A infection and cirrhosis. He's naive to treatment. He's completed rehab, and he currently lives in a recovery home. So he does not use any illicit drugs at this time. So patient case 1, Gabriel, our Express Scripts form that we looked at first, was approved. And you can see here that I've pointed out that you should document the dates of approval. This is very important because you will only be able to get prescription refills during these dates of approval. If the patient needs to change certain medications due to drug interactions, or for some reason cannot start treatment at a certain time, you will need to extend the prior authorization PA date. So that's important to note when you receive the approval what those dates are. So after a patient has been approved through insurance, what is your next plan or your next action item? So if you do not have a specialty pharmacy in your health system, then we would send the prescription to a specialty pharmacy. And we would highly encourage you to build a relationship with a specialty pharmacy that specializes in hepatitis C treatment or is familiar with these types of forms. If you have a local specialty pharmacy, that's great. There are some larger chain pharmacies, but kind of the smaller is the better. That will help out with these PA forms and appeals. But after it's approved, they should be able to run the test claim and ensure approval and determine the copay. So if a patient is approved for treatment, there's 3 different groups that they will fall in. If they have Medicaid, if they have federal insurance, so Medicaid, Medicare, or TRICARE, they do not qualify for assistance through drug manufacturers. For our Medicaid patients, most of the time the copay is between $0 and $3, at least in Tennessee, or very affordable for the patient. So those patients typically do not require additional copay assistance following approval through the insurance. However, for our Medicare population, oftentimes these patients will still have very high copays, upwards of $1,000, that they're unable to afford. And while they are not eligible for manufacturer discounts, you can obtain foundation assistance, we'll talk about in the next slides. For patients who have commercial insurance or non-federal insurance plans, they should qualify for a manufacturer copay card. And the copay cards bring the copay down to no more than $10. So you can see no matter what patient you are, no matter what type of insurance you have, you really should not be paying more than $10 for your copay. And I've listed just the different copay cards that are available through the drug manufacturers. Every drug manufacturer has a copay card program, and you can just Google basically Harvoni copay card or whatever the drug is in copay card, and that information should come up. For all the Gilead medications, they all bring the patient cost down to $5. Abbvie also brings their medication costs down to $5. And BMS is $0, but it must be used in combination with Sovaldi, which is a Gilead medication, so that would be $5 as well. And then Merck's drug Zepatier is also $5. So all patients with non-federal insurance qualify for these types of copay cards. For our patients who have Medicare and need grant funding, these forms can be found online, and they typically require the yearly household income for the patient, the household size, whether they're retired, whether they have filed taxes, and they can be submitted online. And here you can see a list of the different grants that we typically use. I will say most of the time we use PANF or PAF. Some specialty disease states, these grants will close and not receive funding. To date, we have not had any issues with any of these grants closing and not receiving funding. So you can see on the right that what the maximum income is. So it's 400 to 500% of the federal poverty line, which most of our patients have qualified for. And the grants will have a maximum. So we have had patients who meet the maximum of $25,000 or $30,000 per year, and you can actually reapply for an additional grant. And we've had great success in getting those grants covered as well. So just to recap all of that, patients with Medicaid should pay less than $10 depending on your state copay programs. Medicare patients typically pay $0 after insurance coverage and grant funding is applied. And then our patients with commercial insurance should pay $0 to $5 depending on the medication after insurance approval and copay cards. So you can see that though these medications are very expensive, they're usually not cost prohibitive once approved by the insurance. So we'll go back to our cases. Unfortunately, our patient case 2, our TennCare patient, was denied. And you can see here, this is the letter that we received. It says they're denied, but it doesn't really give any information as to why. So the patient does not meet criteria for approval. Please appeal. So now what? Oftentimes it's really helpful to call the PBM and ask about the rejection. So why is the medication rejected? Is it because there's a preferred agent that could be a simple fix to the other medication? Or is it because the patient doesn't meet clinical criteria based on that PBM's guidelines? And what are the next steps? So some PBMs will accept an appeal, like I showed in that first kind of graphic slide. Some want to go straight to a peer-to-peer review, and some will do an external review. I will say by and large the first step is appeal after a PA denial. So then you want to write the appeal letter and then fax back the appeal, the original PA paperwork, and any supporting documentation that you can have. And we'll kind of run through what those options are. So what should your appeal letter include? First is the reason for request. So why are you asking for this medication? Why does the patient need treatment? The second is relevant overall patient medical history and current condition. So what is the patient's HCV-related history? Are there any confounding comorbidities they may add to their health-related concerns? And then address the denial. So if you know why the patient was denied, really speak to that and give some rationale behind why the medication should still be approved despite this denial, why the benefits outweigh the risk, why this medication has been selected, and why it is appropriate. Finally, you want to conclude with some likely outcomes with treatment. So if the patient is able to access medication, what are the cure rates? What are going to be the benefits to the patient? And then just restate the request for approval. Some supporting documents that may be helpful. Of course, any of the required appeal information. So if you did not submit that urine drug screen and they really want that, then you need to send that in with your appeal. Patient's complete medication profile. Sometimes they want to know what the patient's currently taking, any relevant lab results, diagnostics, pathology reports, or drug screenings that may be relevant. And then I always include the treatment guidelines, if applicable, and underline sections that really pertain to that patient's case, as well as any peer-reviewed journal articles. So I've gotten as advanced as including the clinical trials, outlining how the patient meets criteria based on the clinical trial information. So you're not alone in this process. It may sound a little tedious and cumbersome, but there is some great support out there for clinicians to help you develop these templates. I will say after you have kind of a template, you get very similar denials patient to patient and insurance to insurance. So after you have kind of an arsenal of appeal letters, it's very easy to kind of just adjust that based on your patient case. There are a number of organizations that have sample appeal letters. This is one through the HIV Medicine Association and the IDSA. You can see the website there. They will help you generate these forms, and again, you can kind of update them, and you can download them and update them based on your patient case. Mavra and Abbvie has also developed a program to help generate a medical exception information letter, and so you can see that this is basically just a template you click through based on your patient case, and they will actually generate the letter for you. You can update it there based on your information. So that's also very helpful when you're trying to figure out how to develop these appeal requests. So I'm briefly going to skim over Lucas's appeal just so you can have kind of an example of what these appeal letters look like. So we talked about his previous hepatitis C treatment history, that he's 1A, that he has cirrhosis, and then the different ways that we use to stage him, including a fibrosure and elastography. And then we address the denial. So given his advanced disease and his risk for hepatocellular carcinoma and decompensation, he should be treated at this time. And denial of treatment in patients with cirrhosis based on his history of alcohol abuse places them at risk for hepatic decompensation. I'll get a little bit more into these in our specific denials that we talk about in just a second, but I really focus this letter on the denial based on him still using alcohol is not guidelines based and is not does not have any literature to support a denial. So here I've outlined that based on AASLD and IDSA guidelines, the patient should be approved even if he is continuing to use alcohol. And then previously pointing out that previously the guidelines said patients who had cirrhosis were highest priority to treat. Additionally, CMS has issued guidance based on the Social Security Act that patients should not be denied treatment based on alcohol or illicit substance abuse. And then again, we describe the outcome with treatment. So if the patient is able to receive this medication, cure rates were 99% in this population based on the trial that we cited here. And then just summarize our entire appeal as to why he should be receiving treatment. List any inclusions that you have there at the bottom, and then include references as well. So he got approved based on our appeal, but I want to run through some common denials, as Dr. Chastain pointed out at the beginning, that you may be able to use in some of your appeal letters. So one common denial is early fibrosis. So many states restrict, and some payers restrict treatment to advanced fibrosis or beyond. One thing that we try to do is find any additional reason to treat the patient. And you can see here some things, and these are primarily things that will either improve greatly with hepatitis C elimination, or things that may contribute to more rapid fibrosis progression, such as co-infection or type 2 diabetes. So I try to find any of these things that may be in the patient history and write those into my appeal letter to really show that this patient definitely warrants treatment. Even though all patients with chronic Hep C should be treated, this patient specifically could benefit. Childbearing age is something that we often include in our appeal letters for patients who meet that criteria. Unfortunately, there has been a great increase in vertical transmission rates of hepatitis C, and a drastic increase in hepatitis C among women of childbearing age. As Dr. Chastain pointed out, this is now a screening criteria for all patients who are pregnant. And there was an MMWR from the CDC in 2016 that talked about this increase of hepatitis C in women of childbearing age. And I typically will just Google this MMWR hepatitis C pregnant women. This pops up, and I include this with my appeal letter when I fax it back. Another huge one that I pointed out for our patient in particular is ongoing use of alcohol and illicit substances. And I want to point out that, these patients are usually, that can be very difficult to treat. We definitely worry about adherence, and we want to ensure that they're in the best place possible to be able to take medication and benefit from treatment. But ongoing use of alcohol or illicit drugs does not preclude them from receiving hepatitis C treatment. In fact, there's been data to show that SVR rates are the same, and many of these patients are able to complete therapy at similar rates to patients who are not using alcohol or illicit substance use. So you can see that this paragraph talks about the guidelines and how they recommend treatment in this population. And then the next paragraph really highlights the CMS guidance that was sent to Medicaid agencies in November of 2015 based on the Social Security Act, that really it's illegal to be denying these patients treatment based on ongoing alcohol or illicit substance use. So this is kind of my wording of how I reference those guidances. We have recently received a couple of denials based on adherence readiness, and the denial read, physician or provider has not assessed whether the patient is willing to be adherent to treatment. So there are a number of different questionnaires basically that you can administer to patients to show their readiness. Some clinical practices have these just day-to-day, and all of their patients, they will assess them this way. But PrEP-C is one of the assessments where it goes through and says, is the patient ready for treatment? Alternatively, you could have a statement either from the clinician or from the patient that says, yes, I'm willing to be adherent to the medication. So we've gone through patients with prescription insurance and highlighted from prescription to getting them actually on treatment. Now I want to talk about patients without prescription insurance. And these are patients who are uninsured, have no insurance, or underinsured. Meaning they have insurance, but insurance is not covering the medication. So we're going to talk about patient assistance programs through the manufacturer, and then we're going to talk about how to get the patient the medication. So our underinsured population, so the PA was denied, the appeal was denied, the second level appeal was denied. Now the patient can pursue treatment through patient assistance programs. So most patient assistance programs will cover the medication if the patient does not have any insurance whatsoever. Often they require the patient to either have applied and been denied by Medicaid and not be eligible for VA benefits. Almost every patient that we have had that does not have insurance is approved for patient assistance programs. For those patients who are underinsured, so have insurance but are denied by the insurance, it's a little bit more difficult, and it does vary by manufacturer. For the uninsured population, again, often the easiest group to get approved. The PAP process is relatively simple. It has gotten a little bit more complex over the last couple months and taking a little bit longer, but they require the following. So proof of income, which you can see options there, proof of residency, and then household size. If you have a patient who does not have a proof of income or pay taxes, you can write a letter stating that the patient does not have any income available. Or if the patient is homeless and does not have an address to send it to, you can also write a similar letter of proof of residency, and I've included an example here. So every manufacturer does have a patient assistance program. The eligibility does differ, and you can find all of these on the manufacturer website. So here's an example of Gilead's form. I do want to point out that a patient signature is required. So if you work with a lot of patients who are uninsured, I would print off a bunch of these forms and have them in clinic so the patient can just sign while they're there, and you don't have to send them the form and then them bring it back in or send it back in. Abbvie's program is here through their patient support program, and then Merck also has a patient assistance program. So what if Lucas had been denied? So that means he would be underinsured, and Lucas changed his name to Amelia for this example. But if we went through the patient assistance program and he was denied, you can submit a letter to the exception committee. This is a case-by-case basis, but is an option in most manufacturer patient assistance programs. So we wrote a letter to say why the patient really needs this medication. In this instance, the patient was childbearing age, had F2 to F3, fibrosis, and was not being approved by our Medicaid. And we thought it was very important to get her approved. And we included the original PA, the appeal, basically showed them that we've done everything possible we can to get them approved through the insurance, and it's not an option at this time. And thankfully, she was approved. So after you have the patient approved through patient assistance programs, the medication will either come to clinic or to the patient. For this patient population, we typically have the medication delivered to the clinic. That way I can counsel them in clinic from the very beginning and provide them their first dose while they're there. And then refills can either be sent to the patient's home or back to the clinic. The pharmacy is in collaboration with the drug manufacturers, and so they call the patient every month for their refill, but it's important to note, I would tell the patient that if they don't hear from the pharmacy, they should be calling. Also, if you have any patients who are Spanish speaking or speak another language, it is really helpful to call the patient assistance program and give them a heads up that this patient does not speak English. Please have somebody of that language call the patient to set up shipment of the medication. So we'll briefly run through some on-treatment considerations after you have the patient approved in regards to medication access. So some insurance companies will require a 4-week viral load, so it's important to counsel the patient at the beginning, say we definitely need you to come back to clinic, not only to make sure the medication is safe for you, but that it's also working, and so we can get your refill. Again, I mentioned previously that sometimes if the patient starts later than expected or has an on-treatment viral load that's detectable, we may need to extend that PA. If the patient has any insurance changes, it's important to know that from the beginning. So ask them, do you anticipate any insurance changes in the near future? If so, try to go ahead and get it approved on the new insurance rather than the old insurance. Again, calling the pharmacy 7 to 10 days before you run out is important. And we have had a few instances where patients lost their medication or it was stolen. And emergency shipments can be approved through an insurance company or the drug manufacturer. So those are two different options as well. Counseling adherence is very important, especially in our patients who do have ongoing alcohol and illicit substance abuse. Don't just say it's important for you to take the medication. Really provide tools and a plan. Be specific with your plan on how the patient's going to take the medication, what tools they're going to use to help them be adherent. One website that I like is called myMedSchedule.com. You can list all the patient's medications. You have a list here. You also have a checkbox for a month or a weekly med checklist for patients. So I found that to be helpful in certain patients who have difficulty remembering their medications. And finally, I'm just going to briefly touch on the support that is out there. I do want to mention some priorities at the first visit for clinicians. Educate the patients that this is a process. It's going to take some time. You're not just going to write the prescription. They're going to go to the pharmacy and pick it up. You need to have a number for them. You need to be able to communicate with them as you go through this process. Obtain all the necessary paperwork that you can at the beginning. So if you know an insurance company is going to require your drug screen, try to get that at the first visit. Again, any patient signatures that may be required for patient assistance programs should be obtained at the first visit if possible. And sometimes we'll have our patients sign a release of information if we know that we're going to have to try to get rehab records from a different organization. Again, confirm the contact information, making sure you can stay in touch, and really encourage them to stay engaged. I tell them we're going to keep fighting for you until you get the medication as long as you keep answering my phone calls and keep talking to me. Also, within the first visit, it is helpful to evaluate for possible drug interactions, so you can make any changes to medications if needed at the first visit before the patient is approved. So all of the drug manufacturers do provide provider support. So this is Gilead SupportPath. They help with the prior authorization, the benefits investigation, and PAP screening, as well as copay cards. They also offer educational support after the patient is approved. They will call your patients and remind them to take their medication and remind them of their clinic visits. Abbvie also has a nurse ambassador program where they will call the patients daily if you want them to, if you're on one of their medications. So I would look these up online on the website, the Abbvie website, nurse ambassador program. Merck has a very similar program to help you access treatment. And just finish up, so hopefully this wasn't too overwhelming. Hopefully it shows you that the process can be navigated, but I really want to show, to conclude, how this landscape is changing. So these slides just show from 2014 to 2017 how access has changed. So the liver damage requirements, so having advanced fibrosis or beyond, in 2014, 67% of patients had known criteria, so we even knew what those restrictions were. Now we know all criteria for all states, so that's great. In 2014, there were no states that had the minimum requirement of no fibrosis, and now there are 18 states that will approve treatment at any fibrosis stage. And in 2014, 91% of Medicaid insurance companies required F3 fibrosis or above, and now only 23% of states require that, which is great. In regards to sobriety requirements, which we briefly mentioned, we do know all of the states' criteria now on that. There are 10 states that have no requirement of sobriety, which is up from 0 states, which is great. There are fewer states that require 6 months and a year of sobriety. Seeing improvements in the sobriety requirements, and finally prescriber restrictions, which we touched on. So we know 49 states' criteria about prescriber restrictions, and very few states, only 27% now, actually require specialists to prescribe or consult, and only 9 states require a specialist to prescribe. So overall, we're seeing great improvements in access. The current state is that overall it's very much improved, as Dr. Chastain pointed out, the article that came out last week. We still see some barriers, but we are hopeful that we'll have decreased costs and increased competition and increased access. I want to highlight these access resources for clinicians. Again, there's a ton of resources out there, and definitely collaborate with specialty pharmacies, develop a relationship with specialty pharmacies. Really complete those prior authorization forms completely and thoroughly the first time. Identify someone within your clinic, if you're going to be prescribing this frequently, that may become familiar with these requirements and have more experience. Try to obtain all the necessary workup at the beginning if possible. Incorporate a discussion about the process of accessing treatment in your first visit with the patient. Again, document the approval rates and really ensure that 4-week lab completion. So in summary, though costly, the price of hepatitis C treatment should not limit the prescribing of these medications. Complete documentation can improve your approval rates. Do not give up after an initial PA denial. There's multiple steps you can still take after that. Uninsured patients with low income are the most likely to be approved for treatment, so really don't let that prevent you from prescribing treatment. And manufacturer and other organization support is available to prescribers. So with that, we will take any questions that you may have. This is our contact information. We're both very available for you as you have questions.
Thank you, Dr. Zuckerman and Dr. Chastain, for this wonderful presentation. If you have any questions, please submit it through the question box on your control panel or use the hand raise icon and your line will be unmuted. While we wait for some questions, I would like to remind all attendees to please complete the post survey that help us with our webinars and improve our training and technical assistance activities. All right. The first question is, how do we get a consult from GI without having to send the patient there and spending more money in the process?
Sure, and I'll take that question. I think each particular state and each particular region is changing their approach as far as what resources are available and what partnerships may be available. I could tell you what the solutions have been in my region and within Tennessee, but it doesn't necessarily apply everywhere. It also is important to highlight that certain payers will accept certain forms of expertise more readily than others, and there may be different systems in place. There are national hotline for recommendations. The University of California, San Francisco has a hepatitis C call-in consultation line that is freely available, that experts may be contacted with questions about treatment selection and treatment management that may actually support sufficiently options for additional input. There's also a variety of distance learning opportunities and partnerships that can be developed. Obviously, one of the more long-standing and developed programs is the Project ECHO program that's active in many different states and many different areas, which is often set up as provider to provider. But there are also different programs that can be established in relationships that can sometimes facilitate that role. Dr. Zuckerman briefly mentioned the South Carolina AIDS Education Training Center, where they have a webinar twice a month, which is set up as taking clinical cases and questions from primary care as well as rural providers to help with hepatitis C management as well as treatment selection. And many of their primary care providers within their state and outside their state have utilized that relationship to fulfill the recommendations or the needs for GI or infectious disease specialist recommendations. So if you have specific questions or concerns, I would encourage you guys to reach out to us and we can give you specific information about either that University of California San Francisco hotline or the webinar that is based in South Carolina that I regularly participate on, or potentially other resources that are available in your region.
Excellent. Thank you, Dr. Chastain, for that information. I believe that I'm going to answer this question. The question is, can we have a copy of the slides for the presentation? The answer is yes. We are going to send the slides to all webinar attendees after this webinar is over. In addition, you can go to our website, www.nchph.org, where you can find the webinar recording and the slides. There is one more question in the queue. The question is, are there any patient assistance programs for patients who have no proof of residency? We are a health center serving agricultural workers.
Yes, and really that requirement is more so an address, a physical address, and not as much a proof of residency. So either Gilead or Abbvie, one of them does not require a proof of citizenship, and I'll have to get back to you on which one it is, but one of them does not require proof of citizenship. And I actually spoke at the Latino HIV Hepatitis C conference last month, and I had multiple people voice that they were able to access treatment for undocumented patients. So it is possible.
Right. Thank you, Dr. Zuckerman. And I don't see any additional questions in the queue. So if you have any additional questions, you can send me your questions, and I will make sure that Dr. Zuckerman and Dr. Chastain receive your questions. So please visit our website at www.nchph.org, where you will find information on upcoming webinars and publications and information on our annual conference and information on one-on-one training and technical assistance. You can also join our mailing list when you are going to get HERS updates on Medicare, funding opportunity information, senior programs information, and other resources and services for community health centers. You can also follow us on social media, on Twitter, on YouTube, and Facebook. And if you have any additional questions, you can contact us. And my email address is right there. You can also contact our program director or the manager of policy research and health promotion if you have any additional questions. One more time, I would like to thank Dr. Zuckerman and Dr. Chastain for this wonderful presentation. And thank you so much for attending this webinar. Thank you and have a great afternoon.
Thank you.
Thank you.